Hello and good evening, everyone. Welcome to the 110th Blue Hills Virtual Seminar. Blue Hills Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And today's platform is sponsored by Tankara Technologies for the LANAT project in collaboration with Blue Health Ethiopia. So to say a little bit about LANAT project, LANAT is a comprehensive platform dedicated to offering valuable information on pregnancy, childbirth, and the initial stages of childhood development. So additionally, LearnNat offers the convenience of doctor consultations for individuals seeking professional advice. Moreover, LearnNat features a marketplace that showcases a diverse range of maternity-related products, providing a one-stop solution for the needs of expectant mothers. So LearnNat has entered into a collaborative partnership with Blue Hills Ethiopia with the primary objective of enhancing the expertise and knowledge of LearnNat's medical professionals, particularly focusing on the intricate aspects of pregnancy. So this strategic alliance is geared towards providing specialized training and upskilling opportunities for doctors associated with LearnNat, ensuring that they are well equipped with the latest insights and advancements in the field of obstetrics. So Blue Hills Ethiopia is a medical consultancy company founded by medical doctors and a computer engineer, and we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge and preventive medicine. And I'm your host, Dr. Ihenot Adela, a general physician and first aid trainer from Blue Hills Ethiopia. Today, it's a pleasure to have Dr. Dawit Mesfin here with us again to have a presentation on normal labor. Normal labor. Dr. Dawit Mesfin is an obstetrician and gynecologist. He is also the assistant director of obstetrics and gynecology department at Zauditu Memorial Hospital. If you have previously missed seminars provided by Dr. Dawit Mesfin, you can access them in our YouTube channel, which he have given lectures on different obstetrics topics. So you can find it in the Blue Hills YouTube channel. Dr. Dawit, the stage is all yours. You can begin.
Thank you, Doc, for your kind introduction. Is it audible? I think it's audible, right?
Yes, it's audible.
Okay. So today's session will be on normal labor, and I'm Dr. Dawit, an assistant professor of GYN from Zauditu Memorial Hospital. And so basically, today's session will be on normal labor, how is a normal labor progresses, what are the cardinal steps, and what are the things that makes it to be normal, which is different from the abnormal labor. So basically, in order to understand what normal labor means, uh, labor we have to be able to define what labor is. So basically, labor means it's a process where the uterus contracts. Okay, normally the uterus will contract irregularly prior to the onset of labor, which is actual labor that we say the labor that occurs during the time of term or above 37 weeks. But these irregular contractions that occur before 37 weeks, okay, they might be painful, sometimes might be less painful, kind of pushing down sensations, okay, which we call them Braxton Hicks contractions, okay. So basically, to say labor, the labor has to be regular, okay. Not only regular, it has to be strong enough so that it could be able to dilate the normally closed cervix, and also it has to thin out the normally closed and thick cervix. So by doing this dilatation and by doing this effacement or thinning of the cervix, it will finally end up in delivery of or letting out the product of conception, basically the baby with the placenta and the membrane. Okay, so this is how we actually define normal labor, normal, just basically labor. Okay, so this labor has its own characteristics. Basically, whenever we say normal labor, the normal labor has its own characteristic. It means it has to be away from any complications, which means it shouldn't be associated with any preeclampsia, previous scar, multiple pregnancy, APH, or the labor shouldn't be achieved, or the delivery shouldn't be achieved with some kind of induction or augmentation. Okay, if it is accompanied with this kind of risks, basically we're not going to consider it to be a normal labor. The other thing that makes a normal labor normal is it has to be spontaneous. Means basically it shouldn't be achieved by induction or augmentation. Okay, we shouldn't ripen the cervix. We shouldn't start induction with oxytocin or something other things. Okay, so it has to occur by its own. Okay, and the other most important thing is it has to be term. Okay, sometimes labor spontaneously can occur before the time of 37 weeks. So we don't consider that to be a normal labor, okay? Because the product is going to be preterm, okay? Preterm has its own complication, which is abnormal. So always we consider normal labor if it occurs during the time of 37 weeks to 42 weeks, which is considered to be a term gestational age, okay? And the other thing is the presentation. Okay, we do have different presentations. It could be cephalic presentation or vertex, could be shoulder, or could be bridge presentations. The only presentations that's going to be included as normal is going to be the vertex presentation. Okay, so the baby has to come with a normal occipital anterior presentation, which is a vertex presentation. That is going to be considered to be normal. Occipital posterior, occipital transverse, okay, face presentations, brow presentations are not considered to be a normal labor characteristics, okay? And the other and most important thing is the duration has to be in the normal range, okay? The duration has to be normal for latent phase as well as for active phase of labor, okay? And basically the delivery, okay, and the delivery has to be assisted with minimal or minimal assistance, okay. We don't need to intervene in a major way, okay. So it has to be a minimal assistance. Basically the baby can deliver without any assistance in most of its parts, okay. So with minimal assistance, if we help to deliver, okay, then it's going to be considered as a normal labor. And the outcome is the most important, okay, which means outcome for the baby as well as outcome for the neonate, okay. So both the outcome for the baby as well as the outcome for the neonate has to, I mean, the neonate and the mother has to be in a safest way, all in a good condition, okay. This is what we actually have tried to explain. It has to be without any risk, okay? It has to be spontaneous. It has to be term pregnancy, and it has to be vertex, okay? And it has to be basic. By the way, cephalic presentations. There are different types of cephalic presentation. Vertex presentation is one of the cephalic presentation. Cephalic presentation means it could be vertex, it could be face presentation, it could be broad presentation, it could be inciput presentation. Okay, so these all are cephalic presentations. The normal presentation, cephalic presentation, is considered to be vertex, which means occipital anterior presentation. Okay, and the other thing that makes it normal is with minimal assistance, the delivery process, and normal duration of labor, okay, both for latent and active stage. And the other most important that we have tried to say is the outcome, both for the neonate as well as for the mother. The outcome has to be good, okay, all in a healthy condition. Okay, so now the most important thing that we need to be able to know whenever we discuss about normal labor is the issue of parturition or the issue of the process of giving birth. Normally, evolutionary speaking or evolutionary perspective, when we see the delivery process of the animals as compared to delivery process of a human being, is quite different. Okay, basically, it is quite easier whenever we talk about parturition of the animals, because the birth canal is more of a straight shot, a straight canal. Okay, so which means the delivery process in the case of animals, it doesn't take a much sophisticated rotations, okay, or flexions. But whenever we see the delivery process of a human being or a bipedals, okay, basically the canal is not as such a straight shot or a straight tunnel. It is somehow a curvilinear part, kind of genital tract. So the baby has to pass through this curved part of genital tract, not in an easy way. Okay, it has to adjust itself so that it's going to be accommodated in the birth canal properly. And the diameter of the birth canals are different in the inlet, mid pelvis, and the outlet. So basically, for the baby to pass easily, it has to rotate, it has to adjust itself so that it can pass easily through the birth canal. So basically, that makes it different whenever we consider it with that of the animals. Okay, and basically, other than this thing, there are initiations are required both in endocrine, paracrine, and autocrine signaling uh, on the fetus, uterus, placenta, and the mother for the initiation of parturition. Good. So whenever we talk about parturition, basically parturition has four phases. Okay, so these four phases are different. Okay, the longest phase is the phase one, which is called the quiescence phase. Quiescence means the time of absence of anything. Basically, the uterus at this quiescent phase is unresponsive to any signals. Okay, which means it's not going to contract. It's not going even if it has some kind of mild contractions. Those contractions won't result in a kind of cervical softening or cervical effacement, or ripening, and so on. Basically, so it's a period of quiescence. It's a period of no activity. We can say it like that. Okay, so it's a longest period. Uh, During this time, there are different molecules which makes it the uterus to be unresponsive to any action. Okay, and also there are immune tolerances that protect the baby. Okay, basically there are plugs in the cervical canal that protect the baby from the external infections, external anything. Okay, so there are immune tolerance step, and the basically during the time of this antepartum period or during quiescent period, the cervix is soft. It is soft, but it doesn't mean that it is ripened or it is thinned normal title. It is but relative to the non-pregnant cervix, it is more of engorged with vessels, it is more softer, and it's more glandular and dischargeful. Okay, so this is the characteristics of the phase one or the quiescent phase. Whenever we talk about the second phase or the activation phase, it is basically when a woman enter into term pregnancy, okay, or whenever in the normal process, which is a preparation of labor. So whenever we talk about preparation of labor, the preparation includes the preparation of the uterus as well as preparation of the cervix. Okay, so the uterus, basically those chemicals during the phase one that protect the uterus from to be unresponsive will be ablated or will be removed so that they will be replaced by inflammatory mediators, basically or chemicals that are important for the initiation of labor. Okay, so basically this will help the uterus to contract, and this contraction basically will result in dilatation and softening of the cervix. Okay, so this occurs during the term time or after 37 weeks of gestational age. So once this contraction gets stronger, regular, and make able to the cervix to dilate or thinned out, then phase three will enter, which is a stimulation phase. In this phase, definitely the uterus has gained its true contractile ability, regular contractile ability, and also the cervix will be well dilated, well effaced. And usually, if there is no other problems, okay, it will result in expulsion of the product of conception, which is the baby, the placenta, and the membrane. Okay, so this will end up the phase 3, the phase of stimulation. Okay, the phase of stimulation. In this phase of stimulation phase, basically the labor will not only depend on this parturition phase, which is chemicals that result in uterine contraction and dilatation in cervix, but also it could be depend on the power of the woman. It could be the passenger factor like macrosomia and malpresentation and other things could also affect this phase, and also the passage, basically the bony pelvis, okay, any soft tissue tumors that could obstruct the baby from delivering and so on, okay. The piece, basically the power, passage, and passenger could affect this phase or the phase of stimulation, okay. And finally is going to be after delivery of the baby in the placenta and the membrane, then the uterus will regain its previous form, which is going to be called the uterine involution. And due to birth, okay, the cervix can be minorly traumatized, okay, and that will be start to get repaired. And finally, the breast will start to produce milk, okay, which is called the time of breastfeeding, okay. So this is a phase of involution, okay. And finally, the fertility is going to be restored. So these are the phases of parturition, okay. There are 4 phases, which is the quiescence phase, the activation phase, the stimulation phase, and finally the involution phase. Okay, so when you see this graph, basically, you can, I'm going to share this slide for you, but at least you have to, you can see there are chemicals, hormones that are responsible at each phase of parturition. At phase 1, okay, as you can see, the red colored words or hormones are responsible, basically. The purple ones, the 2 purple ones, for example, in phase 2, the progesterone and the prostaglandin, they are responsible both at phase 1 and phase 2 sometimes, okay? At phase 1, both on the uterus as well as on the cervix, okay? The red ones are responsible on the myometrium, okay? So if the purple ones, they are responsible both on the myometrium as well as on the cervix, okay. So you can get this slide and you can see the, the, the hormones responsible at each phase. Okay, so coming to the mechanism of labor, normally as I have tried to explain earlier, the mechanism of labor for animals and humans are quite different. It's more of difficult and sophisticated in the time of humans. It's just because of humans are bipedal, and the structure of the birth canal is somehow, the architecture of the birth canal is somehow, it's curved and with different diameters at each gates, okay. So the baby has to go through these gates in a different form in order to pass through the canal, okay. So basically the mechanism of labor is going to be first engagement, where the baby will start to meet the outer bony pelvis or pelvic inlet, okay, and then it's going to descend, flexion, internal rotation, and then extension, external rotation, and expulsion. We're going to see each and every one by the next slide. Okay, so as you can see on the figure, the first one is called engagement. Engagement means basically the baby is going to meet the maternal bony pelvis, okay, or the outer pelvic inlet for the first time. Usually, the baby is going to engage to the pelvic outlet in the occiput transverse way, okay. Most of the time, it's going to be in the right occiput transverse, okay. That is the most of the babies going to engage themselves to the maternal pelvis, okay. So one thing that you need to know about cardinal movements of labor are the steps are sequential, but they are more of overlapping, okay? Overlapping. There is not such a definite area to say engagement and descent, internal rotation. most of the time they are sequential and they are more of overlapping type of movements. Okay, so once the baby engage, okay, it's going to enter into the pelvic bone. Okay, it's usually it's እንግዲህ በጎን ሆኖ ነው የሚገባው ህፃኑ usually in the right occiput transverse ሆኖ ነው የሚገባው. The reason is it has to accommodate, it has to be able to pass through the pelvic inlet. Normally biparietal diameter which is 9.5 and less one is the only diameter that could be able to pass through the pelvic inlet. ለዛ ነው ልጁ ወደ ጎን ዞሮ in the right occiput transverse ወይም in the left occiput transverse ሆኖ ወደ ፔልቪክ ኢንሌት የሚገባው ማለት ነው። ዋንስ ከገባ በኋላ the process will continue. It's going to descend. ቀስ እያለ ወደ ታች መውረድ ይጀምራል ማለት ነው። So once it gets into the pelvic inlet ለመግባት ምን ያገኘዋል? ቤዚካሊ እዚህ አካባቢ ማለት ነው። ኦኬ ጀስት ከዚህ ወደ ዲሰንት ወደዚህ ነው የሚሄደው። ኦኬ ልክ ፔልቪክ ኢንሌት ጋር ሲገባ ኦብስታክል ይገጥመዋል። አናዘር ዲያሜትር ማለት ነው። የፔልቪክ ኢንሌት ዲያሜትር ማለፍ መቻል አለበት። So in order to pass that pelvic inlet diameter, it has to adjust its shape. Okay, so how does it do that? Basically ምን ያደርጋል? ዲሰንት ፍሌክስ ያደርጋል። እዛው እንዳለ ፍሌክስ ያደርጋል። So the only diameter that could pass through the pelvic inlet is the suboccipital-brachmatic diameter. It is the smallest diameter that could be able to pass through the pelvic inlet. Okay, so እዚህ ጋር pelvic inlet ጋር ምን ሆነ ማለት ነው? መጀመሪያ ኢንጌጅ ያደረገው ዲሰንት ያደረገው ፔልቪክ ኢንሌት ጋር ሲደርስ ኦብስታክል ስለሚገጥመው ፍሌክስ ያደርጋል ማለት ነው። ፍሌክስ ያደረገበት ዋናው ሪዝን ምንድነው? ቱ አቺቭ the smallest diameter ነው which is the suboccipital pragmatic diameter. So that diameter is the only diameter that could pass through the pelvic inlet ማለት ነው። So then after it passed through the pelvic inlet, okay, then it will have a capacious space ይገጥመዋል። okay, ስለዚህ እዚህ ጋር ምን ያደርጋል ማለት ነው? it will rotate ያደርጋል። ኢንተርናል ሮቴሽን ያ ማለት ፊቱ ወዴት ይሄዳል? እዚህ ጋር እንደምታዩት ሶስተኛው ላይ ፊቱ ወደ ማተርናል ፖስቴሪየር ኤሪያ ፌስ ያደርጋል ማለት ነው። ኦኬ ሶ ይሄ ፔልቪክ ኢንሌትን ፓስ ካረገ አቴን የሚያደርገው ስቴፕ ይሆናል ማለት ነው which is internal rotation. once it achieve its internal rotation achieve ካረገ በኋላ ዜን አውትሌት ላይ ደግሞ ምን ያገጥመዋል? ኦብስታክልስ ያገጥመዋል። ኦኬ ሶ ሂር the levator ani muscles, the perineal muscles, okay, and the vulvar, the perineum, okay, will have impact ይኖረዋል እዚህ ጋር። ስለዚህ ይሄ ልጅ ለመወለድ አሁን as you can see the ኖርማል ሌቨል ላይ አንደኛው ክራይቴሪያ ነው ምንድነው? vertex presentation which is occipito anterior ነው ማለት ነው። አንድ ልጅ ዲስቴንድ አድርጎ ሲወጣ እንግዲህ ሲዋለድ አይታችሁ ከሆነ ቤዚካሊ መጀመሪያ vulvaውን ዲስቴንድ የሚያደርገው እና የምናየው የህፃኑ ጭንቅላት it's called the vertex ነው which is occipito anterior ነው under normal circumstance ማለት ነው። ልክ እዚህ ጋር የምታዩት አራተኛው ላይ እንደምታዩት ያለው ልጅ ማለት ነው። ሶ ይሄ ልጅ የት ደርሷል? ኢንተርናል ሮቴሽን ጋር ደርሷል ማለት ነው። አፍተር ኢንተርናል ሮቴሽን ለመውጣት ምን ማድረግ አለበት ይሄ ልጅ? በዚህ ጋር በvulvaው ለመውጣት ወደ ላይ ኦኬ ቤዚካሊ ምን ማድረግ አለበት? ኤክስቴንድ ማድረግ አለበት። ኦኬ ሂር እዚህ ጋር እንደምታዩት ኦኬ ቤዚካሊ it has to extend. The next step after internal rotation is going to be ምንድነው? ኤክስቴንሽን ይሆናል ማለት ነው። ኤክስቴንሽን ከሆነ በኋላ ወደ ነበረበት ይመለሳል። ኦኬ መጀመሪያ ሲገባ እንዳስታወሳችሁት ኦኬ እዚህ ጋር ሲገባ ምን ሆኖ ነው የገባው? ራይት ኦክስፑት ትራንስቨርስ ኦር ሌፍት ኦክስፑት ትራንስቨርስ ሆኖ የገባው። ልክ እንደዛው ይመለሳል። ኦኬ ከተመለሰ በኋላ አንደኛውን አንቴሪየር ሾልደሩን ያወጣል and then posterior ሾልደሩን ያወጣል ማለት ነው። ቤዚካሊ እዚህ ጋር እኛ የምናደርገው ሊትል የሆነ አሲስታንስ ነው የምንሰጣቸው in order to normal labor ላይ there is no as such a problem. ቤዚካሊ እንግዲህ ልጆች ሲወጡ ኤክስቴንሽን ምናምን ስለሚኖር ፔሪኒያል ትራውማ ምናምን እንዳይኖር ቤዚካሊ we are going to assist little assistance ነው የምንሰጣቸው ማለት ነው። this is a characteristics of normal labor and this is what we call it the cardinal movement of labor. The first one being engagement, then it's going to descend, pelvic inlet ያጋጥመዋል። pelvic inlet ፓስ ለማድረግ the smallest diameter መሆን አለበት which is going to be the suboccipital brachmatic diameter. okay and then ልክ ፔልቪክ ኢንሌትን ፓስ እንዳደረገ ካፓሺየስ ስፔስ ያጋጥመዋል and then ኢንተርናል ሮቴት ያደርጋል። ኢንተርናል ሮቴት ማለት ፊቱ ወደ ማተርናል ቬርቴብሬ ያዞራል ማለት ነው። ይሄ ልጅ ለመውጣት ከዚህም በኋላ ምንድነው የሚፈልገው? ኤክስቴንድ ማድረግ ነው የሚፈልገው። ኦኬ ዜን ኤክስቴንድ ያደርጋል። ልክ እንደ አገባቡ ሁላ ምን ይሆናል? ሮቴት ያደርጋል። ኤክስተርናል ሮቴሽን ኦር ሬስቲቲዩሽን እንለዋለን። ይሄኛው ከዚህም በኋላ አንቴሪየር ሾልደሩን ዴሊቨር እናደርጋለን። ፖስቴሪየር ሾልደሩን ዴሊቨር አድርገን the whole body is going to be delivered ማለት ነው። this is cardinal movement of labor. Okay, so the other one is to understand the stages of labor. Basically we do have three stages of labor, which is the first stage of labor, the second stage of labor, and the third stage of labor. Okay, so in the first stage of labor, what we have is just from labor onset to the full cervical dilatation. እዚች ጋር አንድ ዲስከስ የምናደርጋት ኤሪያ አለች። ሌበር ኦንሴት ማለት መቼ ነው የሚለው ዊል ዲስከስ ኢን ዘ ኔክስት ስላይድስ but from labor onset to fully cervical dilatation is going to be considered as first stage of labor, and second stage means from full cervical dilatation up to delivery of the delivery of the baby is going to be the second stage. Okay, and third stage is going to be from delivery of the baby up to delivery of the placenta. Okay, so coming to the first stage of labor is further divided as latent phase and active phase. አንድ ማወቅ ያለብን ነገር ያው we do have some demarcations አለን 4 centimeter ስትሆን or 5 centimeter ስትሆን we say she's in active first stage of labor እንላለን። okay, but what is really logic behind to say she's in active, she's in latent? okay, ይህን ነው ማወቅ ያለብን። okay, basically it's not the centimeter that demarcates whether she's active not latent not የሚለውን ሰርቪክስ ቁጥሩ አይደለም ወይም 5 መሆኑ or 4 ሴንቲሜትር መሆኑ አይደለም ቤዚካሊ ያን አክቲቭ እና ላተንት ብለን እንድንለይ የሚያደርገን it is basically the rate of cervical dilatation is a factor that makes us to demarcate latent and active. Okay, we'll come to see it later, but usually cervix specifically preemi ላይ 1.2 ሴንቲሜትር per hour ዳይሌት ማድረግ ሲጀምር okay, then that is the point where we consider it to be active phase የምንለው ወይም ደግሞ መልቲ ላይ with 1.5 centimeter per hour dilate ማድረግ ሲጀምር then we consider it to be active phase እንለዋለን ማለት ነው basically. latent ግን just basically consider የምናደርገው from onset of labor to accelerated cervical dilatation ያለውን time then we consider it to be latent. active የምንለው ደግሞ from that accelerated cervical dilatation የሚከናወንበት ታይሚንግ it's called the active phase ነው እንለዋለን ማለት ነው። ኦኬ ሶ ቅድም ለማንሳት እንደሞከርኩት what is basically to say onset of labor? onset of labor የምንለው መቼ ነው? ኦኬ onset of true labor እንግዲህ we do have true እና false labor አለን። ያው by saying true labor ነው የምንለው usually regular የሆነ ቅድም እንዳለው strong የሆነ regular የሆነ ኦኬ እየጨመረ the intensity is gradually increase እያደረገ ኦኬ ዱሬሽኑም ኦኬ frequency of happening ምን እየሆነ ሾርትን እያደረገ የሚመጣ ሌበር is going to be true labor. usually we cannot prevent or ፔኑን በአናልጄዚክ ልናቆመው አንችልም and usually ወደ ታች ብቻ ፑሽ የሚያደርገን ከፊት ለፊት ሎወር አብዶሚናል ብቻ ሳይሆን usually associated with back pain ያለው ሲሆን we consider it to be true labor እንላለን። the contrary ያለው irregular ከሆነ ሎወር አብዶሚናል ብቻ ፑሽንግ ከሆነ with analgesic የምናቆመው አይነት ከሆነ ምንም አይነት ሰርቪካል ቼንጅ የማያመጣ ከሆነ ያ ማለት ፌስ የማያደርግ ወይንም ደግሞ ዳይሌት የማያደርገው አይነት ከሆነ ሌበሩ then we consider it to be false labor እንለዋለን ማለት ነው። so this is a point. true labor የምንለው ይሄን true እና false laborን ቤዚካሊ መጀመሪያ መለየት it is very important. the reason behind is ምንድነው true labor እና false labor ካልን okay we are going to start counting time ስለዚህ ካውንት የምናደርገው ለምንድን ነው? ታይም ካውንት የምናደርገው ቤዚካሊ ኢንተርቬንሽናል ስለሚሆን አንዳንዴ ፕሮሎንግድ ላተንት ስንል ዊ ሃቭ ሪዝን አይደለ? ላተንት ፕሮሎንግ ካረገ ዜን ዊ ሃቭ ቱ ኢንተርቪን እንደማለት። ስለዚህ ኢት ኢዝ ቬሪ ቬሪ ክሩሻል ቱ ዲፍረንሺየት ዋት ኢዝ ትሩ ኤንድ ዋት ኢዝ ፎልስ። አንዳንዴ ፎልስ ሌበሮችን ትሩ ሌበር ብለን አንኔሰሰሪ የሆነ ኢንተርቬንሽን ላይ ልንወጣ ስለምንችል ማለት ነው። ኦኬ ሶ ዚስ ኢዝ ዘ ሞስት ኢምፖርታንት ቲንግ ዛት አይ ዋንት ቱ ዲስከስ ኦን ዲስ ስላይድ። ኦኬ ሶ this as you can see, this guy is called Immanuel F. Friedman. This is the most famous person whenever we talk about the progress of labor. Okay, uh, I mean this is the first person to discover what is latent first stage of labor and what is active first stage of labor. For the first time describe ያደረገልን ሰው it's called Friedman ይባላል this person. It is very historical now. It was his wife's ሌበር ሞመንት ላይ ነበረ ፎር ዘ ፈርስት ታይም ይህን ነገር ፕሪዲክት ያደረገው። ምንድን ነው ያደረገው? ቤዚካሊ ሚስቱ ምጥ ላይ ነበረች። ዜን ሂ ፕሎትድ ኮንትራክሽኖቿን ፕሎት ማድረግ ጀመረ። በየስንት ደቂቃዎቹ ነው የሚመጣው፣ ስትሪንግዛቸው ምን ያህል ነው። ዜን ደግሞ ሂ ስታርት ቱ ፕሎት ሰርቪካል ዳይሊቴሽን at every time, at each hour. Okay, and then finally what he got was when he tried to just join the dots, he started to find a curve. Okay, basically sigmoid curve አይነት አገኘ እና that was the first graph or partograph that was created. Okay, in order to follow labor. Okay, it's called the Friedman curve እንለዋለን። Basically the Friedman curve, it has three divisions ነበሩት። የመጀመሪያው ዲቪዥን it's called the preparatory division ይባላል። ይህ ዲቪዥን ቤዚካሊ ላተንት ፌዝ ያለው ነው። okay, the second one is called the dilatation division which contains the active phase, and the pelvic division የመጨረሻው ሌታ አክቲቭ እና ሰከንድ ስቴጅን የሚያዘው ፓርት ነው። so as you can see, this is a curve that he developed. Okay, it has three divisions. The first one is called the preparatory division, the dilatation division, and the pelvic division. On the preparatory division, usually it is a latent phase, no, consider የሚያደርገው most of its part is latent now, and then it has some part of active component አለው, which is the acceleration phase የምንለው አለው ማለት ነው። The dilatation phase is purely, it is a active phase now, or which is associated with maximum ስሎፕ ያለው ማለት ነው። ፌዝ ኦፍ ማክሲመም ስሎፕን አቴን የምናደርግበት ነው ማለት ነው። ኦኬ ኤንድ ፋይናሊ ዘ ፔልቪክ ዲቪዥን ነው ያለው። ይሄኛው ፔልቪክ ዲቪዥን ላይ ቤዚካሊ ሰከንድ ስቴጅ ዲሰለሬሽን ፌዝ እና ሰከንድ ስቴጅ የሚገባበት ዲቪዥን ነው ማለት ነው። ቱ ዲቫይድ ኢት ሞር ቅድም እንዳልኳቸው ይሄ ላተንት ፌዝ ነው። ኢት ኩድ ቢ ዲፍረንት ፎር ፕሪሚስ ኤንድ መልቲስ ዲፍረንት ሊሆን ይችላል። and then finally ሌት ፕሪፓራቶሪ ዲቪዥን ያለው አክሰለሬት ፌዝ ኦፍ ስሎፕ ይሆናል። ዜን ማክሲመም ስሎፕ ይሄዳል ሰርቪክሱ ኤንድ ፋይናሊ ዲሰለሬት ያደርግና ሰከንድ ስቴጅ ትገባለች ማለት ነው። this is the plotting that he got whenever he follows his wife during the labor process, which is actually interesting. Okay, so we actually consider ላተንት የምንለው እንግዲህ ላተንት ነው። ላተንት ዋንስ ዊ ዳያግኖስድ ትሩ ሌበር ነው ብለን ካልን እየቆጠርን ነው ማለት ነው። which means ላተንት ብለን ልንጀምር ነው ማለት ነው። ኦኬ ሶ ላተንት usually in multis is stays for 14 hours ነው። this is standard textbook describe የሚያደርጉት ነው። ኦኬ and for premise it stays up to 20 hours ይቆያል። ኦኬ usually giving time, proper time during latent phase of labor usually prevents intervention. unnecessary የሆኑ ኢንተርቬንሽኖች እንዳናደርግ ነው የሚያደርገው። as long as the baby is fine, as long as the biophysical profile, breathing movement, gross body movement, fluid, okay, እነኚህ የመሳሰሉት ነገሮች ሁላ as long as okay እስከሆኑ ድረስ giving time, adequate time for latent phase of labor is going to be very important ነው in order to avoid unnecessary interventions። ያው እኛ ጋይድላይን ላይ It's 8 hours usually. Okay, but it is good to give time. Okay, individualize again time መስጠቱ it's very important. Okay, and the other thing is active phase ነው። ያው እንግዲህ active phase ገባች ማለት አንዲት ሴት ቤዚካሊ ሰርቪክሷ ኢፌስመንቱ በትንሹ 80% እና ከዛ በላይ ነው ማለት ነው። ኦኬ and at least it is more than 4 centimeter ነው እንደማለት ነው። ኦኬ we'll come to that and also ቅድም እንዳልኳቸው the the fact that latent እና activeን የምንለየው it's not because of the cervical dilatation አለ ብዙ ጊዜ okay it is by the rate of or the rate of cervical dilatation okay cervical dilatation በ1.5 centimeter per hour ዳይሌት እያደረገ ከሆነ then we consider it to be active ገብታለች እንደማለት ነው okay and 1.2 centimeter per hour in preemie ከሆነ then we consider it to be active ገብታለች ማለት ነው ለፕሪሚ okay that's what we consider ይህንን ስናወራ ነው ብዙ ጊዜ as you can see here in the figures 50% የሚሆኑት ሌበሮች አክቲቭ የሚገቡት አት ታይም ኦፍ 4 ሴንቲሜትር ሲደርስ ነው። ያ ማለት ምን ማለት ነው? 50%ዎቹ ሰርቫይካል ዳይሌቴሽናቸው በ1.5 ሴንቲሜትር ፐር አወር ወይም ፎር መልቲስ ኤንድ በ1.2 ሴንቲሜትር ፎር ፕሪሚስ ዳይሌት ማድረግ የሚጀምሩት በ4 ሴንቲሜትር ሲደርሱ ነው እንደማለት ነው። ኦኬ ኤንድ ዘ ሴም ቲንግ እዚህ ጋም 5 ሴንቲሜትሮች ላይ ደግሞ ያን ያህል አቴን የሚያደርጉት 74%ዎቹ ናቸው። 89%ቱ ደግሞ 6 ሴንቲሜትር ላይ ነው ይህንን ሴንቲሜትር አቴን የሚያደርጉት ፐር አወር እንደማለት ነው። ኦኬ እዛ ነው ብዙ ጊዜ አሁን የድሮ ጋይድላይን ላይ አክቲቭ ገባች ብለን የምናወራው ብዙ ጊዜ 4 ሴንቲሜትር ላይ ነበር። አሁን ላይ ግን ስቲል ኢን አወር ጋይድላይን ዘ ኒው ጋይድላይናችን ሚኒስትሪ ኦፍ ሄልዝ ጋይድላይን አክቲቭን ኮንሲደር የሚያደርገው 5 ሴንቲሜትር ላይ 5 ሴንቲሜትር ላይ ዜር ኢዝ ስተዲስ ነው ስተዲስ ስላሉ ነው ቤዚካሊ ስቲል ፊገሩ ላይም እንደምታዩት 5 ሴንቲሜትር ላይ የሚገቡት ስንት ፐርሰንት ናቸው? 74% ናቸው። more by 20% from 4 centimeter ማለት ነው። So it's logical to consider 5 centimeter as active first stage of labor. ከዚህ በላይ ኮንሲደር ማድረጉ አኔሰሰሪ የሆነ ኮምፕሊኬሽኖች እንዲከሰቱ ያለ ለምሳሌ መልቲ ከሆነች ቤዚካሊ አፍተር ዲስ ሴንቲሜትር she might not attain the regular ሴንቲሜትር ፐር አወርን ላትከተል ትችላለች። she might deliver within 30 minutes ከ6 ሴንቲሜትር በኋላ መልቲ ከሆነች ኦኬ ሶ ቤዚካሊ ኮምፕሊኬሽንስ አር ፕሪሲፒቴት ሌበር ሆም ዴሊቨሪ ትራንስፖርቴሽን ላይ ዴሊቨሪ የመሳሰሉት ኮምፕሊኬሽን ፔሪኒያል ቲፕ ፒፒኤች የመሳሰሉት ሀይ ሊሆን ስለሚችል ኮንሲደሪንግ 5 ሴንቲሜትር አዝ አክቲቭ ከት ኦፍ ፖይንት ኢዝ ሎጂካል ኤክስፕላኔሽን ነው ማለት ነው። ኦኬ So this is what WHO and the Ministry of Guide adopt ያደረግነው latent phase is up to 5 centimeter ነው okay and active ደግሞ ከ5 centimeter to fully dilated so whenever we say this regular painful contraction መኖር አለበት effacement እና cervical dilatation መኖር አለበት with recommended rate of dilatation ማለት ነው okay so the other one is second stage of labor. Second stage of labor, basically, the guidelines say for preemies, it has to stay at least 3 hours, okay? And for melties, at least 2 hours. With epidural anesthesia being given, we can go up to 3 hours for preemie, and for basically 4 hours for melty. I mean, for preemie, and 3 hours up for መልቲ ልንሄድ እንችላለን ማለት ነው okay so this is a recommendation okay but whenever we wait this much hour in preemies and melties during second stage we have to see the progress of labor okay when even within 1 hour we expect some kind of descent some kind of change okay and that we have to be sure that she has adequate uterine contraction and we have to be sure that there is no change in liquor and we have to be sure that adequate progress of labor okay has to be attained whenever we wait otherwise this much hour could also affect the baby definitely okay so biophysical profile fetal heart rate pattern meconium status, okay, and descent has to be checked during the second stage of time. Okay, so these are some factors that we may consider whenever we have prolonged second stage of labor, like whenever she's induced in labor, choriamnitis, maternal age, occipito-posterior malposition, basically, okay, delay in pushing, non-black ethnicity, epidural anesthesia, okay, these are some factors that possibly could prolong the second stage of labor. Okay, so the other one is the third stage of labor. Third stage of labor basically it means from delivery of the fetus to delivery of the placenta. Okay, so we expect the placenta to be delivered after the baby within 5 to 10 minutes. Okay, these are the recommended time. But if it's not achieved within these 5 to 10 minutes, we can wait it up to 30 minutes. Okay, after managing with the trotonic agent, after giving oxytocin and so on. Okay, we can wait up to 30 minutes without any other manipulation. Okay, and on the 30th minute, then we may be able to diagnose as retained placenta, but still, on recent guidelines suggest to repeat the oxytocin that was being given, the international unit, okay, and to go for another 30 minutes, okay. But at the end of the 30 minutes, then we may try to deliver by manual removal of the placenta. Okay, that has to be done carefully under our setup with possible sedation and analgesia as well. Okay, so as you can see here, there are two types of placental separation. Okay, so whenever the after delivery of the baby, the uterus will start to contract. Okay, so whenever the uterus contracts, it will disturb the place of the placenta. So the placenta will start to separate from the uterine wall. Okay, that's a mechanism of separation of the placenta and delivery of the placenta. So as you can see here, the separation of the placenta could be from the center or it could be from the periphery. Okay? So from the center, it's called the Schultz method, and the Dukan's method being when the separation of the placenta is starting from the peripheral area, okay, not from the central area. Okay. So anyway, these are the two mechanisms of placental separation in delivery. Always, whenever the placenta is delivered, okay, we may have gush of fluid, gush of blood, and we also have lengthening of the cord. These are the signs of the placental separation. Okay, good. So the other thing that we need to know is management of normal labor. We have to be able to know the admission criteria. Any woman who have labor or pushing down sensation, okay, we're not going to admit her. Okay, so we need to have a strict criteria to say true labor. One thing is very important. We have to be able to define or differentiate which one is true labor, which one is false labor, one thing. And the other most important thing is among the true labors, those that reach to 4 centimeters and above, okay, are considered to be active. And those are the candidates for admission to the labor ward. Okay. And the other one is even if they are not in the active phase, sometimes they may be preeclamptic, they may come with rupture of membrane, or they may come with bleeding, okay, during early labors, okay, like 3 centimeter, 2 centimeter, and so on, okay. So in that case, they are a candidates for admission to the labor ward. Okay, so these are the two criteria that we need to entertain whenever we are planning to admit mothers to the labor ward. Okay, so after admission to the labor ward, okay, we have to be warmly and friendly accepted because they are in pain. Basically, these are mothers who just conceive due to different factors and have this pregnancy for the past 9 months. Okay, so they are in desperate to have the baby, they're worried and so on. So we need to be charming, we need to be warming, and we need to be friendly. Okay, and we have to be able to check the maternal and fetal condition as much as possible immediately, okay, in order to detect if there is any complication or if there is any signs of imminent delivery, okay. And the other most important thing is we need to check her ANC records, her follow-ups, visits, if there is any complication detected during the time of antenatal care, if there is any birth preparedness plan done on the time of antenatal care, and so on, okay. And the history physical examination has to be done for this during the time of labor. Okay, sometimes things could be missed during the antenatal care, which could be found during the time of labor. So as much as possible, we have to take again the new history again, and we have to revise the old histories. Okay, if there is no decades investigation done during the time of antenatal care, we have to do that. Specifically, the blood group RH, VDRL, PICT, and so on has to be repeated if they are not done. And the other most important thing is hemoglobin is very important, urinalysis if possible, if not done. Okay. And the other thing is, since we're not going to allow more attendants to the labor ward, okay, we have to regularly update the clients as well as attendants about the condition of the patient. That is very, very important. Okay. And as much as possible, and if possible, if available, we have to be able to provide them with loose-fitting gowns during the time of labor. Okay, and about the issue of contraception. Okay, if possible, we have to be able to check the antenatal care follow-up whether she decided to take any long-term preparedness. I mean, long-term contraception. Okay, but if she's in latent, still there is a possibility of counseling. But already if she's inactive in a very painful contraction, then we are not going to counsel her. Okay, we are not going to counsel her. It's going to be done during the immediate postpartum period. Okay. The other thing is about the management during labor. Okay, during labor, whether it is inactive or latent, we have to be able to take vital signs. Okay, parameters like temperature, pulse, BP has to be evaluated every 4 hours. Okay, but if she has any complications, like if she's prolonged term prone patient, she's at risk for coronary arrest. Okay, so in that case, basically we have to take this pulse temperature at least hourly. Okay, at least hourly. This is very important thing to do. And the other thing is the position. Okay, the positioning while she's laboring. Okay, there are some misconceptions. Previously, we don't allow them to mobile here and there. Okay, we don't allow them to sleep on the right side. Okay, or to walk and to labor at the same time. But now, okay, new guidelines, studies, and everything show it is capable of the woman during labor to to labor at different positions except the supine position. Okay, basically the reason behind for supine not to be allowed is the gravity stress will have a pressure effect over the inferior vena cava, which is a vein which collects blood from the lower extremity and return blood to the heart. Okay, so if this gravity stress, if the woman sleep in supine position, basically this gravity stress will compress the vena cava and venous return will be decreased to the heart, which in turn will decrease placental perfusion and fetal heart rate compromisation and so on will happen. So we don't allow them to be in supine position, but other than supine position, she can labor both in the left and the lateral decubitus position. She can labor while walking, okay, and everything. This is possible ways of uh, laboring, okay. And the other thing is the issue of oral intake. The issue of oral intake basically, since during pregnancy gastric emptying is somehow sluggish, okay, uh, women who eats during labor, specifically solid diets, even liquid diets, sometimes may make her difficult to digest. Okay, so the end result will be vomiting. Okay, so as much it's not as such a hard and fast rule, but it is good to limit solid diets during the active phase of labor. Okay, so she can take in the latent phase, but whenever she is entering into active phase of labor, it is recommended to withhold the solid foods and keep on taking the liquid diets. Okay, but they are not. These studies are not as such a strong one. Okay, not strong one, uh, due to the the reason that we push food, solid food is the issue of vomiting, and the issue of anesthesia if there is any for intervention and so on. Okay, and so the other and the most important thing is the IV fluid. Okay, so IV fluid is not as such must should not be indicated for every woman who came to the labor ward. Okay, unless otherwise any indication. For example, if she's meant to take medications like fluid and so on for hydration and so on, then basically she can be on IV fluid. But otherwise, for any purpose, for no reason, we are not going to secure IV line and give fluid. Okay, oral hydration is only the effective one. Oral hydration enough. Okay, unless she's exhausted and so on. Okay. The other and the most important thing is about companionship during labor and childbirth. So companionship during labor and childbirth ያው በተለምዶ ሆኖ we don't allow attendants and to be in the labor ward, okay, as much as possible. ብዙ ጊዜ አንመክርም, but the reason is having these companions like relatives or well-trained companions like the so-called doulas, okay, uh, they are very important for different purposes. One thing is they are going to manage pain. Okay, the non-pharmacologic approach of pain management could be given by these attendants or doulas. Basically, uh, there is a significant reduction in the use of analgesia. Okay, and also the use of oxytocin for induction, and also there is studies that shows there is a decreased incidence of operative vaginal delivery and cesarean delivery rate. Okay, so it is one of the commonest pain management, which is a non-pharmacologic pain management, is like having this companionship. These doulas are common in the Westerners. They are trained professionals, basically, who just provide not only physical but also emotional, informational support. Okay, they can get these patients before the time of delivery, during the delivery, and sometime even after delivery. Okay, so this part of labor management is the most important part of labor management. Okay, so the other one is a pain management. Considering pain management, like I have started to explain earlier, we do have two types of pain managements. One is a non-pharmacologic and a pharmacologic method. The basically the pharmacologic methods, they basically help to relieve pain, but they're not going to relieve anxiety and suffering. Okay, so they have to be somehow be helped by the non-pharmacologic methods. Okay, we do have different techniques of pharmacologic method of relieving pain. They could be water immersion technique, the relaxation techniques like acupuncture, massage, okay, and childbirth education, audio analgesia. This all could basically help the woman to relieve pain during labor. Actually, not relieve pain, but basically it will help her to decrease the to decrease the pain, basically, or to cope with the pain that she's going to have, basically. Okay. We do have different pharmacologic methods of pain management. Uh, the most important and currently the most uh, acceptable and recommended technique of pain management is going to be the epidural anesthesia. Okay. Basically, this epidural anesthesia is going to be given when the woman reaches to active first stage of labor as much as possible. Okay. And the other pain managements, like the petidine, the fentanyl, the morphine, and so on, they can be given. They can be given, but we have to be able to be sure that we are capable of managing neonatal distress or fetal distress during the time of delivery. The most complications that we see whenever we give this petidine and morphine and so on are neonatal depression. So the other part of management is about management fetal maternal condition, specifically fetal condition, which is a fetal heart rate. Normally, for high-risk women, okay, those preeclamptic APH patients, DM patients, scar patients, and so on, the frequency of fetal heart rate monitoring has to be every 50 minutes, okay? And the other one for non-high risk is going to be every 30 minutes, okay? This has to be done after every contraction, okay? After every contraction. We do have different techniques of fetal heart rate monitoring, but the continuous electronic monitoring is also another method of monitoring the fetal heart rate. Um, there are some drawbacks that we have seen whenever we consider electronic monitoring in a continuous fashion. Since it's a machine, there are artifacts, tracings that could mimic that of abnormal metatic pattern. Okay, so studies show that continuous electronic fetal monitoring could predispose for unnecessary interventions like cesarean section, early interventions. Okay, so as much as possible for a woman who has normal progress of labor, clear like her, okay, fetal treat could be checked in an intermittent fashion with Doppler or with Doppler auscultation or fetoscope, like every 30 minutes and every 50 minutes. But those with high risks, okay, if we have, then we can go for continuous electronic monitoring. This is just basically to decrease the intervention or to decrease the rate of cesarean sections. Basically, it will increase the rate of cesarean sections. Okay. The other one is labor progress, digital vaginal examination. Okay. So as much as possible, we have to be able to limit our digital vaginal examination. The recommended during the latent and active first stage of labor is to do PV examination like every 4 hours. Okay. Unless otherwise, we do have concrete indications to do PV examination. For example, if the woman during labor, if she has rupture of membrane, okay, if she has vaginal bleeding, okay, if she has urge to push, okay, or if we are planning to give anesthesia, analgesia, okay, or epidural anesthesia, okay, or if we detect any abnormal fetal heart rate pattern, then we are not going to wait 4 hours to do PV examination, okay? So this could be indications to do PV examination earlier than the expected time. Okay. The other thing is the issue of ARA or amniotomy or rupture of membrane artificially. Okay, there are misconceptions. Actually, it's not misconception. There were studies that say doing amniotomy could possibly shorten the labor process or the duration of labor. But it was not like that. Current studies doesn't prove or doesn't support the issue of amniotomy for shortening of spontaneous labor. Okay, uh, so we shouldn't do rupture of membrane during early labor. Okay, unless otherwise indicated. ያ ማለት ምን ማለት ነው? 3 ሴንቲሜትር 4 ሴንቲሜትር ላይ ሜምብሬኑ አክሰስ ስላደረግነው ብቻ we shouldn't do ARM. Okay, the membrane has its own benefits basically. When the membrane is inflated, bulged, it will have a pressure effect over the cervix and it will help us to dilate the cervix, specifically during preterms, okay? So usually we're not recommending to do amniotomy without any indication. But for example, during early labor, if the woman has fetal heart rate abnormality, could be tachycardia or bradycardia, okay? Then at that time, we may consider rupturing the membrane, okay? We may consider rupturing the membrane. Otherwise, for without any indication, we're not going to do rupture of membrane, okay? The other is the issue of positioning during the second stage of labor, okay? So we have seen ቅድም እንዳልነው during the first stage of labor, okay, I mean during the first stage of labor, አንድ እናት በፈለገችው ፖዚሽን ማማጥ ትችላለች፣ ሌበር ማድረግ ትችላለች ኤክሴፕት ኦን ደ ሱፓይን ፖዚሽን ብለናል አይደለ? በት ኢን ኬዝ ኦፍ ሰከንድ ስቴጅ ኦፍ ፖዚሽን ስቲል unless there is imminent delivery ካልሆነ በስተቀረ ኦኬ still she can labor at different positions. Okay, she can labor in squatting position. Okay, in the left lateral, right lateral position. Okay, even semi reclined ሆና supine position semi reclined ሆና okay to the lateral ትንሽ shift አድርጋ she can labor that way. Okay, so second stage ስለገባች ብቻ አልጋ ላይ ብቻ መሆን የለባት ቤዚካሊ አልጋ ላይ ሆና ሌበር ማድረግ የለባት። ቅድም ለማለት እንደሞከርኩት አፕራይት ፖዚሽን መሆን አንደኛ ሬት ኦፍ ዴሊቨሪን ይጨምራል። ኢት ሾርትንስ ሳምሃው ኢፒሶቶሚ ሬታችንን ይቀንስልናል። ኦኬ በት ዘ ኦንሊ ዲስአድቫንቴጅ ዛት ኢዝ ጎት ዊዝ ዚስ አፕራይት ፖዚሽን ሌበሪንግ ዱሪንግ ሰከንድ ስቴጅ ዘ ሪስክ ኦፍ pph somehow a little bit higher, and the risk of extension or perineal tear, which is more than second degree tear, is a little bit higher as compared to the other positions. Okay, that's only, but considering the usage of operative vaginal deliveries, cesarean section, episiotomy rates, and duration of labor, this position, upright position, squatting position, is the most preferred one, and currently still the advocated one is this positioning. Okay. Okay, so as you can see on the figures, these all positions could be the position that a pregnant woman could attain to deliver during the second stage time. Okay, the other one is the way to push or a method of pushing. Okay, which one is a favorable one? Is it open glottis or closed glottis? Basically በቀላሉ ለመግለጽ closed glottis ማለት ምንም ድምፅ ሳታወጣ ዋጥ አድርጋ ወደ ታች እንደመግፋት ማለት ነው። ላይክ ባውል ሙቭመንት ወደ ታች መግፋት ማለት ነው። ኦፕን ግሎቲስ ግን ሺ ሹድንት ዳት ዋን ሺ ካን ሃቭ አ ቮይስ ስታምጥም ድምፅ እያወጣችም ዲፕ የሆነ ድምፅ እያወጣችም ፑሽ ማድረግ ትችላለች እንደማለት ነው። ቤዚካሊ ቦዝ ኦፍ ዘም አር አክሰፕታብል ታይፕስ ኦፍ ሜተድስ ኦፍ ፑሽንግ some institutions, some guidelines prefer one of it, some don't, basically. Okay, but what's the logic behind in each and every one? Senil, whenever we consider closed the closed glottis slicer ይሄኛው ማለት ነው የመጀመሪያውን ስናስብ ቤዚካሊ ምንም የምታወጣው ድምፅ የለም፣ አምቃ ነው የምትገፋው። ሶ እዚህ ጋር ፕሬሸር ይጨምራል። ኢንትራ አብዶሚናል ፕሬሸር ዊል ቢ ሃየር፣ ኢንትራ ቶራሲክ ፕሬሸር ዊል ቢ ሃየር። ይሄ ቤዚካሊ ፑሽንግ ኢፈርትን ይረዳል። ፑሽንግ ኢፈርትን ይረዳል ዊች ሚንስ ሾርትን ያደርገዋል ፑሽንግ ኢፈርትን፣ ወይም ደግሞ በተወሰኑ ፑሾች ልጁን ሊወለድ የማድረግ ቻንሱ የጨመረ ነው። but the drawback with this one is even if it's shorter ቢሆንም ኦኬ ያው እንግዲህ ይሄንን ስታምቅ ኦኬ ኢንትራ አብዶሚናል ፕሬሸር ኢንትራ ቶራሲክ ፕሬሸር ይጨምራል። ኦኬ ይህ ካርዲያክ አውትፑትን ሳምሃው ማተርናል ብለድ ፕሬሸርን ይቀንሳል ተብሎ ይታሰባል። እንግዲህ ቅድም እንዳልነው ካርዲያክ አውትፑት ከቀነሰ ማተርናል ብለድ ፕሬሸር ከቀነሰ ወደ ልጁም ፕላሴንታል ፐርፊውዥንም ሳምሃው ይቀንሳል። ይሄ ልጁን ትንሽዬ ፌታል ሬት አብኖርማሊቲ ሊያመጣበት ይችላል ተብሎ ይታሰባል ሳምሃው። ኦኬ ዊዝ ኦፕን ግሎቲስ ግን ቤዚካሊ ድምፅ እያወጣች እየተነፈሰች ነው ፑሽ የምታደርገው። እዚህ ጋር ፕላሴንታል ፐርፊውዥን እዚህ ጋር ብሎክ የነበረው ፕላሴንታል ፐርፊውዥን ሳምሃው ኦፕን ነው እዚህ ጋር ኢቨን ኢፍ ኦፕን ቢሆንም ያው the difference between the two is the duration of expulsion is going to be a little bit higher ይሆናል። ይሄኛው ጋር በቶሎ ላይወለድ ይችላል። she might need subsequent pushes ሊያስፈልጋት ይችላል ማለት ነው። most of them are acceptable, both of them are being practiced currently. Okay, for example, in the US usually most obstetric care providers they encourage women to labor with prolonged and closed glottis ነው። ይሄ ሪሰርቾች የሚያሳዩት ነው ቤዚካሊ ማለት ነው። Okay, this is what we actually discussed, the difference between open and closed glottis pushing techniques. Okay, the other one is early pushing and delayed pushing ነው። Okay, ይሄ ማለት ምን ማለት ነው? የትኛው ነው የተሻለው? ቁርጠቷ ልክ ሲጀምር መግፋት ነው የሚሻለው? ኦር ልክ ከጀመራት በኋላ መግፋት ነው የሚሻለው? ኦሬልስ ደግሞ ገና ልክ ሊመጣ ሲል ቀድማ ፑሽ ብታደርግ ነው የሚሻለው ነው? ሞስት ሪሰርችስ ፕሪፈር the delayed pushing. Okay? Yeah, delayed pushing means whenever she feels the urge to push, okay? ልክ እንደጀመራት ትንሽ ቆየት ብላ ፑሽ ማድረግ ብትጀምር it is the most effective way of pushing ነው ተብሎ ይታሰባል። okay? The reason behind it, she might be exhausted. okay? ገና ምጧ ሳይመጣ ቁርጠቱ ሳይመጣ ፑሽ ማድረግ ከጀመረች she will be tired, she will be exhausted, okay? And she will be unable to push sooner or later የሚል ሪስክ አለ። and also early pushing final effecቱ ኤክስፔል ስለማታደርገው and she might end up in the usage of obstetric operative vaginal delivery የሚሄድ እድሏም ይጨምራል ተብሎ ይታሰባል። so as much as possible delayed pushing technique ከመጠቀም it's going to be very effective way of taking ተብሎ ይታሰባል ማለት ነው። okay, the other one is the issue management on the second stage is preventing perineal trauma. How do we prevent perineal trauma? ብዙ ጊዜ there are different techniques of perineal trauma prevention. If the um, for example, these are the things, okay? The first one is a perineal massage. This is usually done during the late trimester, okay? Just trying to massage the lower part of the perineum, basically, okay? This will create adaptation and prevents unnecessary perineal tears, at least first and second degree perineal tears, okay? But the other ones is a hands-on approach, which is basically trying to protect the lower part of the perineum with a thumb and the index finger, okay, and helping the baby to go out, okay. This is not only done by the hand, but also with the support of a gauze, okay. This is a usual one that we use basically in every places, okay. We don't practice this perineal massage, in fact, okay. The other one, which is obsoleted and not used currently, is the Ritigan's maneuver. Okay. Here, what we are going to do is basically we are going to insert our finger through the anus of the pregnant woman. Okay. And then we are going to elevate the chin upward. Okay. አገጩን ወደ ላይ upward ማድረግ ማለት ነው. And then the baby's head will be supported by በአዘር ሃንድ ማለት ነው። በሌላኛው እጃችን የጭንቅላቱን ሜንቴን እናደርጋለን። በሌላኛው እጃችን ደግሞ በአነስ በኩል ቺኑን ኢሊቬት እናደርጋለን ማለት ነው። This is not being practiced currently and it is very invasive and traumatizing and painful for the woman, basically. Okay? Okay. The other thing is that we have discussed earlier is on the third stage management from delivery of baby to delivery of the placenta is basically we have to look for signs of separation of placentas. Okay, these are lengthening of the cord, a gush of blood coming out from the vagina. These are signs of third stage of labor. Okay, so the rest will be managed accordingly. Okay, the other thing is on the active management of third stage of labor, we do have three components, as we all know. The first one is the eutotonic medications. Okay, these are oxytocin, misoprostol, okay, as much as possible. Ergometrin, if you have, okay, these are the eutotonic medications that we use in most setups. Okay, specifically oxytocin and misoprostol. We don't have ergometrin nowadays. The other one is control contraction, which is the most important part of third stage management. Okay, basically we say controlled because we're going to hold the uterus upward, okay, and we do apply gentle cord traction downward. Okay, the reason of doing this is we are going to prevent uterine inversion and unnecessary cord cutting. Basically, with unnecessary cord traction, we may cut the cord. So gentle traction helps the uterus not to invert, and basically it also helps the cord not to be cut. Okay. because if these things happen, basically we are going for manual removal of the placenta, more or less, or manually removing or replacing back the uterus to its back to its normal position. Okay? The other is a uterine massage, which is going to be done every 15 minutes for 1 hour. Basically, we are stimulating the pacemakers, which are found on the fundal area of the uterus. Okay, so basically, this will help to create signals that makes the myometrium to contract. Okay, this contraction will basically contraction of myometrium basically will clamp the vessels that are going through them, which helps to prevent bleeding. Okay. The other in the last one that I'm going to discuss is about delayed and immediate cord clamping. Currently, the recommended one is to have a time of 1 to 3 minutes before cutting the cord. Okay, we shouldn't run for clamping the cord. Basically, after delivery of the baby, we have to put the baby on the maternal abdomen. Okay, and we have to check the baby. Basically, if the baby is crying, if the baby has breathing, okay, if their tone is very good, the heart rate is very fine, then we have to do for routine steps first. Okay, we have to dry the baby's head, neck, chest, extremities, the back. Okay, and we have to stimulate. We have to be able to be sure that the baby is crying and so on and so on. Okay, and then finally we can go for just after whenever we are assessing these things, it takes around 30 seconds to 1 minute. Then after that, we are going to clamp the cord. Okay, whenever we clamp the cord, basically we have to measure 2 fingers from the neonate's abdomen. We have to mark, and another 2 fingers from the marked area upward. We have to mark and clamp. Then in the middle of the 2 clamps, then we have to cut. Okay, so that is a standard method of clamping and cutting the cord. Okay, and we shouldn't basically cut before 1 minute. Okay, and above 3 minutes. Above 3 minutes, the risk of autotransfusion, the risk of hyperbilirubinemia, polycythemia, hyperbilirubinemia is going to be higher. And if before one, basically for preterms, autotransfusion is going to be helpful or for the neonates, okay, from the mother. So basically waiting 1 minute is going to be very important for the neonates, okay? So the standard one is 1 to 3 minutes. I think these are my references. Thank you all for your attention.
Thank you very much. So we can move on to the question and answer section. So participants, if you have any questions related to today's topic, could you please write it in the chat box so doctor can address them. Yeah, there's one question by Talan Sefa, if you can see it. By Talan
Okay, one
Sefa.
question. Yeah. Episiotomy not indicated even in premise. So the issue of episiotomy is not uh, a reason to give for premise. Okay, if the only the reason to give episiotomy is the perineum, if the perineum is tight, and if delivery of the baby's head could potentially result in unnecessary perineal tears. Okay, that's the only reason. Sometimes, by nature, the vulvas could, during pregnancy and so on, even in preemies, the vulvas could be a little bit laxed, okay, so that they could be able to deliver the heads without any, with minimal support and without any episiotomy. That could necessitate no episiotomy for the woman, okay, and sometimes small babies in preemies, okay, may not need may not necessitate any episiotomy. Okay, so basically, episiotomy is not a reason to give for preemies. Okay, so የምንሰጠው basically indication ሲኖረን ነው። Okay, indication ሲኖረን ነው እንጂ preemies ስለሆነች ብቻ we're not going to give episiotomy.
So one other question was by Sanam Ibeltal is
Yeah,
what is the deceleration?
yeah. Among the Friedman curve, the last part of the Friedman curve, as I have tried to explain earlier, is the division phase, okay? The pelvic division phase. So on the pelvic division phase, okay, the descent is going to go down, okay, and finally the maximum slope will start to decelerate, okay, will start to decelerate. It's not going to go up as it comes during the dilatation phase. ልክ ዳይሊቴሽን ፌዝ ላይ እንደነበረው ፍጥነት ኦኬ መሄዱን ያቆምና it will go slow down decelerate ማድረግ ይጀምራል ኦኬ that is a final part of basically cervical dilatation when it potentially or fully dilated ከሆነ በኋላ አቴን የሚያደርገው የሰርቫይካል ስታተስ up until it gets deliver እስከሚሆን ድረስ ቤቢው ያለው ፌዝ it's called the deceleration phase now, okay? Once it reaches to deceleration phase, then it goes to second stage እንለዋለን ማለት ነው basically, okay? So that's what deceleration phase, which is going to be a part of the active phase or late active phase, basically after 7 centimeters of dilatation. What's the best time to do ARM? Basically, ARM is not indicated. ARM is not indicated unless indication ከሌለን okay? Normally, nature also, when the cervical dilatation reaches to late active, specifically 6 centimeter እና 7 centimeter ሲደርስ by nature there will be ARM ይኖራል artificial ሳይሆን spontaneous rupture of membrane ይኖራል at 7 or 6 centimeter of dilatation ላይ natural ማለት ነው otherwise we don't basically recommend to do ARM there is no best time to do ARM, okay? We need to have indication. For example, at 3 centimeter, if the woman has non-reassuring fetal status like bradycardia or tachycardia, then at that time we may consider doing ARM in order to check the liquor status, okay? If she has whether meconium አላት ወይ or is there any abruption አለ ወይ then that's an indication to do ARM. Otherwise, for normally progressing labor with no fetal rate abnormality and so on, there is no reason of doing artificial rupture of membrane. Nature will take care of it by it's okay. The other question, vaginal birth, natural birth can be safer than cesarean section. Is vaginal birth safer than cesarean section? Why most pregnant women choose to undergo C-section? Is there any recommendation? Okay. There is no wallet. Yeah. It is known, no, vaginal birth is the safest way of delivery, no, as compared to cesarean section. ያው ኔቸር has its own take care mechanism አለው ብዙ ጊዜ እና vaginal birth is a preferred way of giving birth ነው rather than C-section. But if there is indication, we go for cesarean section, okay? That is very important for the baby as well as for the mother, okay? The reason that these days most pregnant women tend to choose cesarean section rather than vaginal delivery is two things. One is the pain, okay? One is the pain. The reason is we don't have adequate pain mechanism. We are not finding here and there epidural anesthesia አናገኝም okay? So if there is epidural anesthesia here and there, most of the time people will be on the side of vaginal delivery, okay? Because whenever we do cesarean section, there are complications related to the surgery, okay? Risk of complications during the future pregnancy, risk of complication related to the anesthesia, okay? Or the medication that's going to be given for a pregnant woman, whether spinal ይሁን J ይሁን, okay? There are risks አሉ ለእናትየው, okay? So basically ይህንን ሁላ ሪስክ ውስጥ ከመግባት vaginal delivery natural birth is a preferred ነው most of them የሚመርጡበት ዋናው ምክንያት ፔን ቶለሬት የማድረግ ቻንሳቸው ዝቅተኛ ስለሆነ so ፔንን ማኔጅ ማድረግ የምንችል ከሆነ during labor the rate of vaginal delivery will be definitely higher okay? So in order to manage pain, the most acceptable, the most recommended currently is epidural anesthesia, okay? So we may not find epidural anesthesia here and there ልናገኘው አንችልም ግን still in አዲስ ራሱ in different private hospitals in St. Paul and Blackline sometimes, okay, they are start to give this epidural anesthesia, okay? So in the near future, definitely this epidural anesthesia will be available in every centers. So the rate of vaginal delivery will be higher ነው ብዬ አስባለሁ ይሆናል ብዬ አስባለሁ if the reason is pain ከሆነ the other is the issue of knowledge okay most of the time we don't tell properly what is the pro and con of having vaginal delivery and what's the pro and con of having cesarean section okay so if they know what could possibly the risks of having cesarean section unnecessary cesarean section ምን ኮምፕሊኬሽኖች እንዳለው በትክክል ኖሌጀብል ብናደርጋቸው ዱሪንግ the antenatal care usually they will be on the side of natural birth or vaginal birth so the two things pain and knowledge they are important factors to choose between vaginal birth and cesarean section the other is can maternal request be indicated for c-section in our country still on the standard guidelines, maternal consent is also an indication for cesarean section. It is, but in our setup, it is not an indication. In our country, it is not an indication to do cesarean section. It's not an indication. We don't do in the public as well as private centers. We don't do cesarean section for maternal requests, basically. As long as we tell them properly the risks and complications associated with this, usually maternal request is not an indication and we don't advise them either. But if they push, sometimes there are centers who do maternal with for maternal request. But one thing that you need to know in our country, it's not an indication to do cesarean section. It's not an indication. Even the other centers, it's even if it is written as indication for cesarean section, usually it's not practiced. Usually it's not practiced. As long as the mother can understand what we are telling her, maternal request shouldn't be the indication for this. Thank you.
Yeah, thank you very much, Doc. It was an amazing presentation. So on behalf of Blue Hills Ethiopia and all our participants, as well as Leonard, I would love to thank you for taking the time to present on our seminar. And as I have said in the beginning, it's not the first time that Dr. Dawit is in the Blue Hills virtual seminars platform, and he has already given lectures on multiple topics related to obstetrics care. And you can find the videos to Dr. Dawit's lecture in our YouTube channel. So, Dr. Dawit, if there is anything that you would love to add, let me give you the stage one more time.
Thank you, everyone, for your participation and for your comments and questions. And this is a major topic that we need to understand whenever we have or whenever we face obstetrics wards. So we're going to have this abnormal presentation also on the coming Friday. It's going to be the continuation of this presentation, basically. So I want you all to attend the next presentation as well, and to come with a prepared question if you want to, so that we can have major discussions on that. Thank you.
Okay, thank you very much, Doctor, and good night.
Good night.